let me see. Do you want me to share my slides, or I guess I pull them up? Is that right, Mike?
That's what you told me. No, it's
That's what
fine.
I
Either
told you.
yeah, either way is fine. You just let me know.
Yeah, I want to be able to show them. So let me pull them up. Let me see if I can get them here. I had them up a minute ago and now I've lost them. So I'm going to be talking about some communication strategies, if I can open my slide deck here. So I am going to be talking about some communication strategies, and it's kind of a funny thing to talk about with this group because you are such, this group, most of you, if not all of you, are really experts in communication. You're in advanced studies, you're in fields that require superb communication skills, and you really are communication experts. I hope I can add to that a little bit today with a couple of the things we'll be talking about. And we're not going to go into small group, but there will be some times that we have some conversation, some discussion. Here are the main things I want to talk about today. And this is communication that is appropriate. These are strategies appropriate for clinical encounters, encounters in educational settings, or running meetings, many different kinds of settings. These are just kind of core, some core skills. Again, I know you have a lot of these skills, but I hope I can add a little bit by bringing some of the things I've learned as a clinician educator working with medical students and residents and doing some structured teaching and communication with medical students. We're going to be talking about establishing rapport by addressing feelings, very specifically talking about how to address feelings to build rapport, how to respond to what I call conversation grenades, those comments that tend to kind of fall in the middle of the room and stop the conversation, building trust. And then something that I have not talked about before, this is new territory for me, some of the foundations of inclusive communication. And this is specifically ways of communicating that promote equity. So here are the learning objectives, breaking it down a little bit. We'll talk about some basic skills, establishing rapport, and this would be in clinical or educational or other or meetings in leading conferences. And doing this, I'm going to focus on addressing emotions. And then some of the more advanced skills that kind of grow out of this, that do grow out of it, that we won't get to, is facilitating communication when people don't agree, and to establish trust and build rapport even in challenging interactions. Now, here's a disclaimer. One is that I am not, don't have graduate studies in communication. I'm doing this as a clinician and someone who has been working with medical students. And we have, I used to teach a course in the College of Human Medicine to medical students, which was an 8-week course, 2 hours a week, on basic communication skills. And I'm going to cover all that territory in about 30 minutes. So you can imagine that I'm assuming that you already come in with skills, and also that this is just kind of scratching the surface. So besides those communication skills I talked about for meetings and encounters, I do want to talk about some of the principles of inclusive communication using a health equity lens, talking about some of preferred terms and giving you some resources. And I hope we have time for some conversation, though I know we're trying to get an awful lot done this afternoon. Okay, I should slow down. I talked to you folks about having a reasonable pace. I'm going to try to have a more reasonable pace. So for any encounter, whether this is a clinical encounter, this goes for me when I'm about to see patients in clinic, or if you're entering a therapy session with someone, or about to run a team meeting, or maybe an IEP meeting, there are certain things you want to do to prepare. And one is you want to know the facts the best that you can. You know, if you've got a file, read it. If you can look at the previous medical records or the previous therapist notes or your own notes, take a look. Know the players as best you can, even before you enter the room, and know what the concerns are if you can. Now, in my life as a primary care doctor, frequently I don't have access to very much information before I walk in the room. I may have a one word, what the concerns are, what the medical assistant wrote down. I'm not quite sure who's there. I'm pretty sure my child patient is there, but I don't know if they're there with grandfather or aunt or uncle or parent. But I do have an access to the medical record typically so that I can have a little information before I go. It's important to prepare as well as I can. Once you're into the encounter, you want to start with introductions. And this seems so simple, but we frequently barge in and don't clarify introductions. Who is who? And be sure also, this is something that we have to remember in the pediatric world, to introduce ourselves to the patient, even if it's a tiny baby or someone who's pre-verbal, as well as be sure to include, if there's an individual with a disability or developmental disability, to include that individual in the introductions. Clarify the goals. In a meeting, it makes sense to say, well, let's look at the agenda. In a clinical encounter and probably in therapy sessions, the word agenda doesn't quite make sense, but at least clarify. So what are you hoping to accomplish today? What do we hope to get out of this? And then as you're facilitating the discussion, make space for everyone to speak. Frequently parents or those in the power differential on the lower end of the power differential don't get a chance to speak. And then midway through the encounter, perhaps, but certainly before you break up, summarize and clarify what has been said. Can you say things like, I just want to make sure I understand what we decided here today. This is what I understand. We heard this and this, and clarify. And again, this goes for a meeting, but it also goes for a clinical encounter. And then what are the next steps? What are we going to do from here? Now, this is going to look pretty familiar to you. That listening is really important. Ask, open it up, ask with open-ended questions, speak a little, ask again, really do a lot of listening. But I want to add to that the importance of knowing how to redirect or interrupt effectively. You really often, in many times, you're limited by time. You only have, is it 15 minutes in my encounters? If I'm lucky, I've got 20. You may have an hour for a meeting. You've got to get it back on track if it's going off track, or if somebody is just has trouble stopping. So it's very important to learn some and practice some transition statements that you can use. I'd like to get back to, or you can say, you said something important. I want to return to that. But practice some things to interrupt. Learning to interrupt effectively is an incredibly important skill. Okay, now I want to talk a little bit about addressing emotions. And this is no way to suggest that the people in the Mylan trainees and faculty don't have tremendous skills in this. Just thought maybe to give you something that our medical students are taught might be useful to you. And yeah, and it really does, because connecting to feelings really builds rapport. This has been demonstrated in a lot of the studies about what builds a trusting relationship, what builds rapport, certainly in clinical encounters. Addressing feelings helps. And we often aren't that good at that. We tend to skirt around when emotional content comes up. I've got here a mnemonic that one of my colleagues at Michigan State developed, and then has used with medical students and residents and physicians in practice. Actually, this mnemonic is used in remedial courses for physicians who get into trouble for patients not like, poor satisfaction. To be able to have good ways to address emotions. And this can be for little things or it can be big things. Name it. And here it often, this particular mnemonic talks about the provider, the person in the driver's seat in the encounter, naming the feeling, but you can also ask what the feeling is. So how do you feel about that? But it often works to name something and then give the person some room to correct you if you've mislabeled the feeling. Make a statement about understanding it, show that you respect the feeling. Now, respecting the feeling doesn't mean that you approve of perhaps the behavior that was triggered by the feeling. Punch their fist through the wall, they were so angry. You can respect that if you're feeling angry, but you can, not agree with the behavior. and then provide some support, what you can do about it. I'll give some examples in a minute. Other ways of building rapport is using hope statements. And here, these are typically I statements or we statements, not you statements. A simple hope statement, it gives a positive frame of whatever's going on and shows some alignment with the goal. So you might want to, practice some thinking ahead or work on developing some hope statements that you can use and that you can use comfortably without it feeling false, without feeling like you're acting. A lot of this, when you first start using the mnemonic, it may feel awkward and stilted, but if you practice a little bit and develop in your own language, it can be pretty smooth, and you'll find that it can be very effective. So thus addressing emotions by naming it, understanding, respecting, and supporting can come for even small statements, but it also can be very helpful when dealing with more major emotional statements or outbursts. So let's talk a minute about something called conversational grenades. I don't know where that term came up, but it's a pretty good one. This is something that it's an emotionally loaded statement that you really want to run and hide. You want to turn the other way. You just as soon get up and walk out of the room. Brings the conversation to a stop. I think you can all imagine some of these. And typically what we do is take a gulp and change the subject. So let's think about some ways, some conversation grenades and ways of addressing them. So here are a few that might be conversation stoppers. You've given up on my child. Have you heard that at all? Hopefully not, but I've certainly heard it. I'm praying for a miracle. That's a little scary. It's all my fault. How do you respond to that? And no one understands what we live with. That's hard to respond to because actually it's true. If somebody is living, we can try to live and put ourselves in someone else's shoes, but we really can't. So what do you do with these besides walking out of the room or putting your head under the table or changing the topic? I can remember years ago working with a medical student, and these were simulated interviews, and the simulated patient made a comment about her mother had died 2 years before. They were having she was dealing with some abdominal complaints. And the student looked at her and said, "So tell me again, how often do you have diarrhea?" It was just did not want to deal with the death issue. Luckily it was with a simulated patient. So how do you deal with conversation grenades? Basically, you land on them. The best is to go for it. Don't ignore the statement. This is an opportunity to really break through and make an emotional connection. And a meaningful connection, understanding what they're saying. First of all, don't ignore it and don't assume you understand what it is. It may be, you need to pursue it. You need to find out more. They're often misunderstood. So don't assume the meaning. So it's really helpful to say, tell me what you mean, or I wonder what that means to you. These are comfortable ways of asking somebody what they're meaning. So let's take the one, I'm praying for a miracle. So one way to respond there would be, what does that mean to you? What would a miracle look like? So response could be, my child will be like other children. He'll grow up and get a job, get married, have children. Could be something, so I was going to say as simple as, but this is not simple. He will use the toilet for pee and poop. So let's say that that's the response. Wish he'd use the toilet for pee and poop. So let's think about how to name it. Here's an option. Sounds like you're really frustrated that he's still in diapers. To understand it, it must be exhausting and kind of disgusting to have to change his diapers. Respect it. Any parent would like to have their child toilet trained by this age. And then to support it, I'll work with you to help him learn to use the toilet. This seems pretty simple, but going through it takes just a moment, but you have aligned yourself with the parent. And then for hope statements, a simple hope statement is we all hope he makes progress soon. You don't ever have to change his diaper again. Pretty simple. Here's another one that we can work through together. The mother of a child with autism comments, my in-laws say things, oops, go back on that. My in-laws say things that suggest that his autism is my fault. Comments about what I did when I was pregnant, how I didn't discipline him when he was younger, things like that. So let's think about that. What would you offer for a naming the feeling? How would you name the feeling? Anybody have a suggestion?
Sounds like there's some feelings of guilt.
Okay. Now, is that what you would say to the mother?
No.
Okay.
I'm sorry, can you go back to the previous slide so I can just read exactly the.
Yeah.
So I learned this nurse mnemonic actually in medical school, so it's nice to be able to practice this in a different context. But I think it's really important to try to have, like, I don't want to name that feeling. I want the family member to name it, or because I don't necessarily want to, but I might say something like, it sounds like maybe there are some feelings of guilt around this diagnosis for your son, or that you might be experiencing some accusation from your family members.
Yeah. You know, I might start that even simpler. I might say, ouch, that hurts. How do you feel about that? What do you think about that?
Yeah, I think that maybe opens the opportunity for mom to name the feeling,
Yeah.
and then just acknowledging, using your phrase that, like, you have a shared understanding of, like, what that might feel like.
Yeah. Then we go back to the understand part. Yeah. Because part of it is she may be feeling guilty, or she may be feeling attacked and not, not feeling guilty. She may be just resenting the fact, or we don't know. We don't know exactly, but she's expressing hurt.
And one of the concepts in crisis intervention is to do it sounds like it feels model.
Mm-hmm.
So it sounds like you feel guilty because this. So it's giving them an opportunity to correct it and say, oh, no, it's not guilt, it's anger. But when you use that because part, it shows that you're listening to what they're saying.
Mm-hmm.
So it's a helpful way to name a feeling without putting something on a person.
Yeah.
I like the idea of reflecting the feeling back to someone, but I have found when people tell you something like this, like, oh, I was told this was my fault, they are actually looking for the reassurance of you contradicting them and saying, no, it's not your fault. And so, I mean, I would definitely want to hear a little bit more about what the feeling this person has, but I would also want to provide that for them to, like, hear from an expert, like, this isn't your fault. I think that can be really healing for people who come with this particular kind of, experience.
Yeah, I would start with naming beginning to name the feeling, and then let her elaborate, like, that hurts. How do you feel about that? And then whatever she responds, then whether she feels guilty or the understanding, or she's feeling attacked, then an understanding, I can see how you would feel that. I can see how that would make you feel guilty. And then a little bit more respect. So, this happens in other families, and that you often have the same response that you have. Let's talk, and then support. Let's talk more about this and kind of understand what the reality is. And it's not your fault, and move on from there. this is a complicated statement because there's so many potential complex feelings around it, behind it. But the NERS can be pretty brief and can just open the gateway to having a more in-depth conversation. Naming it, understanding it, respecting it, and then that support. Let's talk about it. Let's sort this out. Or how can I help you communicate with your in-laws that it's not your fault?
Well, and I think those layers are really important because sometimes they're going to have said that same statement to many people. Like I hear from my mother-in-law all the time that it's my fault, and they're going to consistently, maybe, like, I mean, I'm just overgeneralizing, but at the same time, the most common response is probably going to be, no, it's not your fault, from people who know. But just the fact that it's not your fault is not always like a next step kind of helpful. It's important to know and it's important to understand, but that really supporting it, because, you know, when I work with kids or even parents, I'm like, that response, you know, okay, so even if it's not your fault, how do you even respond to your mother-in-law? You know, what do you say to that? And here are some things that maybe you could say versus, because they're, you know, your natural response as a human being is going to be, it is not my fault, get off my back. And you want to give somebody some strategies to be able to work with their, you know, own amygdala, if that makes sense.
That makes a lot of sense. That my first inclination with that, I think most of us is just to sort of say, you know, it's not your fault, you know, to dismiss it, but you really need to acknowledge and address the feeling and then provide that support and do some, explore some strategies together, how to deal with that, how to respond to the in-laws, and also how to, help this parent with her feelings, because even if she knows in her head it's not her fault, she's got some feelings of guilt there, which are being reinforced by in-laws, or it may not be coming from the in-laws, it may be coming from inside. Well, let's move on. I mean, I know since we're would love to talk more about that issue, but I want to talk about another, which is building trust. Have you ever been in a situation where you can just, you know, that the person you're working with doesn't really trust you or is having trouble trusting you?
For me, in my situation, I was in a private school for kids with learning disabilities. And so the only way they were looking for us is if they had already had issues elsewhere. So we pretty much, every parent that came in, there was such a level of mistrust because they had already had such unsuccessful experiences. So that was like the thing that we always talked about with our staff and ourselves all the time, was very much like the hold on. You know, they're not going to trust you just because they walked in the door. They're just because they like you. We've had good, conversations the last 2 months doesn't mean they're going to come to their first IEP and be comfortable. And so making those efforts each time and acknowledging, yeah, this is, this has been tough. Yes, this is different. They're kind of waiting for that other shoe to fall. It can be really hard, and it takes a completely different amount of time depending on a person or their previous experience.
Yeah, I mean, that's a really good example. And I have something that's kind of similar, working in a safety net clinic. A lot of the families I see are not there because it's the clinic they most want to come to. It's the only one that will accept them. And they have often had bad experiences with the healthcare system. And so we don't start from a place of them trusting me. They're coming to me because they need something, or their child needs something, and they're coming. They are not coming. They have not had good experiences. And so I have found that the most effective way to work on that is to address it, to put it right out there. If I have it, and I'll tell you, this has come up a lot lately for me in clinic, talking about COVID vaccines. In the clinic in the Ingham County Health Department, many of the families I'm seeing, the parents have chosen not to get the vaccine, and for a variety of reasons, For many, it's just a not trusting what the experts are saying and I'm not sure if they're getting their news elsewhere or it's hard to know because often they don't want to engage in a conversation, but just not trusting. And I find that I need to just sit down, except unfortunately in that clinic, there's no chair for the doctor. I need to step back and say, you know, in a totally non-judgmental way, I don't expect you to trust me. We just met. You don't know me. Let's work together. And maybe over time, we can learn to trust each other. Careful to use I statements. Don't start with, you don't trust me. It's more, I don't expect you. We just, put it on me. Acknowledge that it develops over time and begin to work with it and not be disappointed. And very much to acknowledge any mistakes or any misunderstandings on my side. Really important. Like if I've misread something in the medical record or I made some assumption, to really acknowledge it. But again, I have found it to be, I can often feel the emotion in the room just relax when I make the statement of, I get it. I wouldn't expect you to trust me. We just met, or if I've met them before, you and I see each other for about 15 minutes, 3 or 4 times a year, and you have a whole life that I don't know. So I need to learn more. Let's see what we can do, where we can work together. And again, I just feel frequently just kind of like a whew, feeling better about it. Often we have those thoughts in our heads and we don't express them. So looking at my clock, we're doing fine time-wise. What we've talked about so far is addressing emotions, establishing rapport and empathy, dealing with conversation grenades, hope statements, and talking about building trust. And I want to say something to this group of professionals about empathy. Do you ever get tired, do you ever get tired of being empathetic?
Absolutely. I call it empathy exhaustion.
Yeah, and it can happen in a day. I mean, one of the things that's tough for us as professionals dealing often with difficult situations is that we feel for the families we're working with, we feel for the kids, we connect, we feel empathy, and then we walk it out of that room and then we walk into another and we start all over. And somehow you have to be in the moment and at the same time be able to leave it behind, to have it real and yet dissociate so you can move on. And then, leave it at the office when you go home. I'm not as good at that as even after all these years, I still have trouble with that one. But yeah, empathy exhaustion. So I think we need to acknowledge that. And I mean, there are some ways of addressing that, one of which is through colleagues, through expressing our fatigue, and then trying to balance our workload so that we have a chance to take care of to take a breath and take care of ourselves. Now I'm going to switch to another topic. And again, this is something that I'm working on, health equity and inclusive communication. And when I say that with a sigh, because I am finding that this is tough. I'm having to relearn my vocabulary. The discussions we've had earlier this year about microaggressions that I've been reading about and learning about and trying to identify, and conversations about ways of thinking about othering people, I am reflecting on how many mistakes I have made and continue to make, unintentional hurts that I'm trying to clean up. So I'm just laying it out there. This is a hard one for me. We're going to be I want to talk a little bit about advancing health equity by changing the narrative and really looking at language and really looking hard at language and using language that is accessible and meaningful to the audience. It's respectful and relevant, and to avoid terms that imply negative conditions that the negative conditions are inherent to a group rather than a condition. I'm sorry, I need to clean up that bullet point there. But sometimes we often use terms that imply that it's the fault of the individual or the fault of the group. So again, I find this hard. I'm having to unlearn some long established patterns of communication. I hope it's a little easier for you as you're coming into this earlier in your career. I mean, not that it's brand new, but I think we're all learning a lot about this. I'm going to present some principles for unbiased inclusive communication. And this, I'm drawing on documents from the American Medical Association, the Association of American Medical Colleges, and also from the Center for Disease Control, and I have the references listed later. There's some documents that really are talking, have what I find to be very good information on starting point for unbiased inclusive communication. So one of the first principles is to avoid adjectives such as vulnerable and high risk. This is hard. I mean, how many grant applications have I helped to write where we talk about targeting vulnerable populations or high risk populations or low resource populations and other groups, or vulnerable people? I'll come out and say, boy, this is a really vulnerable child. I need to think about that. Avoid dehumanizing language. Use person-first language. And we can talk a little bit more about this. We just learned, about how to remember that many individuals would rather prefer identity-first language. I like Alex the Determinator, autistic people, autistic person. There is some, not everyone agrees with person first, but it's probably safest to start with person first and ask the individual, or if you're dealing in a community setting, ask the group how they would like to be labeled. Not that labels are good, but what language they prefer. Remember that there are many types of subpopulations. We tend to talk about vulnerable populations or minorities as an entire group, or Latinos as an entire group, the African diaspora as an entire group, and we need to be more specific, if we can be as specific about the populations, the group, or the individuals we're talking about. Don't just group people together. And avoid language with terms with violent connotations. Target, tackle, combat. There's the war on this disease, or combating that condition, or tackling autism, or whatever. These all have violent connotations. And of course, avoid unintentional blaming. And the fact that it's unintentional, I do it a lot. I won't say that you do, but I will say I do it a lot. So let's get sort of some specifics. This again comes from the documents from the CDC and the American Medical Association. It provides some alternatives. And these are mouthfuls. They're kind of hard for me to switch to, but instead of vulnerable groups, talks to groups that have been economically marginalized or historically marginalized or experiencing disadvantage, or not high-risk groups, but groups placed at higher risk because by this, or experiencing disproportionate rates rather than high-burden groups. Anyone have any comments on this?
I think one thing I notice is, like you said, there are more words this way. And I can imagine getting feedback from like professors and such saying like, oh, you need to be more concise. Like you should just move that word ahead, right? Like I'm just totally imagining all the track changes I would get from doing this in paper. So maybe that's a good conversation point to have with professors, but definitely something that I think I would probably get feedback on.
Probably would. Well, I'll be interested to see too if requests for proposals that come from the federal government start to change the language, because a lot of the requests for proposals ask for us to target these marginalized minorities or something like that. That it'll be interesting to see whether this translates into federal language.
I also think it's helpful to, I think sometimes we try to shy away from naming something. So if you're talking about uh, communities of color, Black and Brown communities, or Black, Indigenous, person of color, that's the catch-all phrase, like say that. If you're talking about the LGBTQIA population, say that. Like you don't just have to say marginalized or disenfranchised, like talk about who you're talking about.
Very good point. Very good point. Be more specific about who are you talking about. We talked about this a little bit, the person first versus identity first. I think you're familiar with this language. It does seem funny to say, people with obesity, but that is better than, you don't want to label somebody. Obesity is not their identity or who they are. Homeless, it's not their identity. I think when you get to disabilities, there are some, the identity first language may be the preferred by the individual or the group. So again, it's wise to ask. And here's something we were talking about a little bit before about, be more specific instead of saying minorities, people from, and then say, if you have a specific racial or ethnic group, name that group. And then avoid these kinds of terms with violent connotations. And there are some nice alternatives that don't necessarily mean you have to use a lot more words. Engage, prioritize, collaborate with, serve, consider the needs of, eliminate a disease rather than combat, just to be kind of thoughtful about the connotations. And here's the unintentional blaming. And when I think about, my conversations regarding the COVID vaccine, I have to catch myself on this of not blaming people, but thinking or using language that blames people. But here, workers who don't use PPE, limited access to, could be limited or uncomfortable with, workers under-resourced. Again, try to change the language to shift the narrative.
And I greatly appreciate that last slide because thinking about it as far as like from the education lens, our kids with ADHD in particular, they're consistently, as we write things, we write goals or we're doing descriptions or we're working with behaviors, it's consistently written like, he doesn't pay attention. He does not do this. He will not listen to directions. No, he's a student with an attention challenge. Like he struggles to pay attention.
Yeah.
He struggles to stay on task. He doesn't independently stay on task is very different than he will not follow my directions.
Yeah, I really appreciate that, bringing that back to the neurodevelopmental disabilities and ADHD. And that's an important language that I try to use with families. He has to work so hard to pay attention.
Yeah.
Focusing is so difficult for him or her. Yeah, and then, help the families to shift that too. Here are a couple of resources. I won't click on this here. You have the access to it, but this is the CDC website. It has some really good stuff on health communication and health equity. And then there are links from that to other resources. And then the second here link here is to the American Medical Association guide, which is a very helpful document. So this is the last of my slides because I was hoping we could have some time, and it looks like we do have about 15 minutes for more conversation about this, shifting the language, or just, how we're doing in our health equity, our efforts to educate ourselves regarding health equity. I'd like to open it up to conversation. Maybe I should end my slideshow and unshare my screen so we can see each other.
So I Do you have a question around equity or a thought? And so if it fits now, that's perfect. If it doesn't, that makes sense to me too. But one of the things as far as health equity that I consistently think about, particularly with some recent journeys of my own, is people with low literacy rates and just the access to information and the processing time that is often needed for people with neurodevelopmental disabilities, because the healthcare professionals don't have the time. Even if they wanted to, they don't have the time to be able to sometimes provide the repetition or the different types of or modalities for information, for the same information, to truly help those individuals make really responsible and healthy health care decisions. And I don't even know if there is work or what work would be done or already exists in that realm in particular.
Boy, Amy, you really brought up an important topic. And this hit me in the face a couple of days ago when I was in clinic and seeing a 12-year-old who spoke English well, and her mother spoke English quite well. There was their first visit and they had a stack of papers to fill out and they had barely started. And then the mother said, "I don't write English." So she spoke English well. So what language did you speak? She says, "I speak Creole." I don't know whether she writes Creole. I didn't want to go there. So we were short on medical assistance and my next patient I had a cancellation. So I decided to help her go through those papers. I'm reading the consent to treatment form. I couldn't understand it. There were statements in there though I understand I'm giving permission to bill my insurance to provide information to my insurance company, but if they don't pay for it, I understand that I am responsible for any further payment. I'm like, she didn't sign that one. She didn't know what service was being offered, but it just really struck home what a huge problem. And even for literate people, the stuff we give people in clinic to sign or to read is often legal gobbledygook. It protects the healthcare system, the corporation, but yeah, I mean, if I didn't have time, we wouldn't have even got basic information from her on past medical history and things. If my next patient had shown up, I don't know. It's a big problem. We need to fix it.
Jane, this is Barbara. I have one particular patient that actually Dr. Torres and I have worked with from Detroit. And we've tried to engage the school district for accessing appropriate services. And while we have, I think, done a pretty good job on our end, it's been an impossible task to for the parent to get through the hoops. And even when we call high-level administrators and talk to them personally for any next step to get accomplished. And so any thoughts the group has about when we're striving for equity and it's beyond the bounds of our institution, what else can we do? It's been quite a struggle.
Well, I think you remember the story that I had here where I ended up going to the school board.
It's true. Yep, I do.
But it wasn't just my going to the school board. A reporter went with me and there was an article in the paper about racism in the school and the people not listening, et cetera. And that got their attention.
That's a really good point. A really, really good point that may be the level we need to go
but
to.
It could have backfired. The reason it worked was once I met one-on-one with the superintendent and we got through the anger, she was really willing to make some changes. So in some ways, it worked. I mean, she now has an anti-racism curriculum as part of her in-services for her faculty and is really working on things. but she's kind of exceptional. I mean, I think many superintendents would agree with that, would do that. But it would have, what made a difference was also the one-on-one that when I met with her. And I'll tell you, the interviewing, the communication skills I just talked about are the skills that I used in that, without trying to, but the skills that I used in that conversation with her. I don't know if I remember if I've talked to this group about it. I met with the superintendent, and she was really mad at me because I had come and there was an article making her district look really bad, and the school board was not happy, and she thought I was just grandstanding, and she was really mad, and I thought she was just putting me off. And finally, about 15 minutes into the meeting, when I wanted to just get up and leave, I was like, I'm out of here. That was what in my head. I'm out of here. I'm out of here. I'm out of here. Instead, I sat back and said, I'm really frustrated. I don't trust you and you don't trust me. I'm just trying to help this kid, and I just feel like I'm running against a wall, and you're trying to protect the district. And let me tell you what the mother has told me in private, because she gave me permission to tell you, and that's what opened it up. So I don't have any great answers for you. That was kind of an exceptional case, but I am using it as an example of both, you leveraging the news, leveraging going to school board, as well as that one-on-one open your heart conversation.
Thank you.
Anyone have any comments about changing terminology? Is this a challenge to anybody besides me?
I think it's brutal. Like, as far as like having been in education for a long time, it's really hard in special education because the whole nature of the concept of special education is the need to focus on the challenges and negative components of a person. Otherwise, you're not eligible for services. And so it's a consistent balancing act between, having to focus on that and have to include that so much, and yet want to be able to lift that person up. I'll be teaching about IEPs in a few weeks, and it's really one of those discussions where this IEP can be like 7 or 8 pages long, and there's going to be like 2 sentences of strengths for this kid. Like, it's like not even arbitrary. It's this little section, and they fill it out because they have to. Like, oh yeah, by the way, what are the kid's strengths? Okay, well, we think he's this, this, and this. Super. And now I'm going to do 4 pages of how much he's like not meeting expectations, how horrible this is, and then what we're going to do to fix that. And it's so hard because it's the nature of the system. So if people only read that, it's like so disheartening.
I have to agree with you, Amy. I think IEP is the most emotionally draining process ever. I mean, every IEP I go into, I have to just prepare myself mentally, because all I hear is all the things that my son can't do, rather than all the things that he can.
Yeah.
And it really, just leaving those meetings every single time, I sit in the car and just cry.
Yeah.
Do any of the professionals in the IEPs acknowledge how it feels for you?
What's that?
And this isn't just for you, Angela, but others in the IEPs or in those kind of, back to the addressing emotions and empathy. Do the professionals acknowledge how it feels for the parent?
If it was fortunate, we worked with a team. I was in a private school. We worked with a non-public staff, and I work in Grand Rapids, and Grand Rapids Public Schools tends to get kind of a bad rap. But our team that worked in our building was very good about that. They were very, very good about acknowledging how much they enjoyed working with the student and what all the positives were. And then we're pretty transparent about the fact that we're going to have these conversations. We want to make sure we illustrate this, and it's not going to be written down on this paper because it doesn't have a place to go. But if it had a place to go, and I always loved that about our speech path and our teacher consultant, I was like, yeah, that's the thing that's missing.
Let me ask and ask others in the group, any thoughts about, Alex had a really nice little videotape there about special needs, about special. And I know I've worked for years with children's special healthcare services, and I take care of kids with special healthcare needs. And, many of you are working in special ed. What was your reaction? Anybody have any kind of, when that videotape, I don't know, Lisa might want to have comment on that. I'm picking on you, Lisa.
No,
Yeah,
you know me, I've been like trying not to
Yeah.
wave my hand. I love that video. I absolutely love that video so much. I could totally see Lily saying, "Get out."
Yeah.
When she does it. Yeah. I mean, it's just really so important to, really remember that, right? We are all, none of us are alike. We're all different. And whether, our IQ is whatever it is, or at whatever point, we just all have our own individualized needs, right? We may like similar things, but, we all have special needs if you really think about it, right? Because none of us are alike, and none of us can go to one place and all of us be happy, right? All of our needs would not be met, and some of them would not be met at all. So if you think about it in that sense, it's just, we are programmed in society to gear towards the middle of the curveball, right? We're geared to those averages, and what the percentage of the most amount of people like, and what the percentage of most people would do, we're not really prepared to deal even a lot of times with those gifted children on the other side. So I how we can go about and be more inclusive and the way the system of education in itself is just, I remember being young and in school, seems like we all read on different levels, but we were in one classroom. And I also remember being, if you went to Mrs. So-and-so, you were in reading level 2, so much I could just go on and on. One thing I did want to think about, like with the IEP, I don't find minor as painful as many people go through, and I don't know if it's just I'm a little more easygoing, but I feel like from the get-go I worked with the team, and actually Dr. Turner was my daughter's pediatrician, and I was advocating for all-day kindergarten, and they only wanted to give her half day, but so I kind of went in there with I want to partner, but I'm not afraid to push boundaries. And they pretty much started with, let's talk about her strengths. What do you see as her strengths? And so I always really appreciate that. I also serve on the Clinton County Parent Advisory Committee. And we've been really trying to we have a new superintendent now, but we've been trying to really focus on how can we prepare families for the IEPs. So many people just don't know what the process is. They don't know who to reach out to, and how can we help them to go in and be an advocate and share their children's strengths with them, or providing like a vision statement and what their child wants and needs are.